Hi, live, hello. Um, in the peace and quiet of my home, I'm doing a Facebook Live this evening. And I am at home, and therefore I will be subject to potential interruptions from family members. So apologies in advance. They are watching a MasterChef, not MasterChef, what is it, Junior Bake Off type program at the moment, and that is looking good. So there should be peace. I don't know if that's on television or just on the sort of iPlayer thing, but hopefully they are nearby my location. But I think we will have some peace for a few moments. So this has not really worked when I first tried it because it said my connection is too weak, and I'm also getting a message on my screen saying your connection is weak. I'm hoping this is broadcasting, so I'm not sure what I can do. I had the problem when I used it at the clinic, so I thought I'd do it at home, and I'm at home, and I've still got, I don't know if we've got a weak internet at home, I didn't know we did, but I'm at the mercy of the elements, and I might get cut off, in which case I apologise. But if I don't get cut off, I'm going to go through some questions. I've got some questions here. I've just seen a question from Marla, was it? You just now put a question saying about implants, so I will answer that question. Textured implants, I think you said, do they cause less capsular contracture, textured implants somehow? So the answer to that is yes. Textured implants give less capsular contracture than smooth implants. The way it went, the sort of natural history was that they developed breast implants which were smooth surfaced implants. Then they developed polyurethane foam implants which had a foam coating. The scar tissue grew into the foam coating, and they found that had a lower rate of capsular contracture. Then they had problems with the polyurethane foam implants, so they said, oh, we can't use these polyurethane foam implants, what can we do? And so they created textured silicone implants which are trying to mimic polyurethane foam. And so this is a textured silicone implant. It's got like a roughened surface, it's not a smooth surface. The problems they had with polyurethane implants subsequently have shown to be perhaps not as bad as they thought, and so we do use this is a polyurethane foam implant. One of the companies, this is actually a Mentor implant, and this company Mentor, the way they make the textured implant is they get the wet silicone and they imprint it with polyurethane foam to try and mimic the foam. So and the idea is that rather than the scar tissue growing as a sheet around the implant, the texturing breaks up that scar tissue so it doesn't form a sheet around there, and so when it contracts it doesn't have such an effect. It's not quite as good as polyurethane foam, which creates a 3D it's a sort of 3D effect as the scar tissue grows into the foam, so that's got a lower rate of capsular contracture than the textured implants, but textured implants have got a lower rate of capsular contracture than smooth implants. So yes, texturing does have an effect on creating less risk of capsular contracture, and that is why it's trying to break up the scar tissue. So thanks for that question. We've also got a question from Deborah from the private group asking about the Homdeski method of breast reduction and why don't we use it because it's got less scarring. I've got to say, I had to look up that method of breast reduction. I haven't heard of it. There's lots of methods of breast reduction. It's not what I was familiar with. The general principle and what the point of this type of breast reduction, she was saying, is it gives less scarring, so therefore that's better. And this is something with a lot of plastic surgery. Everybody wants less scarring. In fact, people want no scarring. And the balance is always that a lot of plastic surgery, a lot of what we do, particularly with contouring the body, which is a lot of what we're doing, whether that be contouring the breast, contouring the tummy, contouring the face, what we're trying to do is tighten the tissues. We're trying to tighten things because over time things lose their elasticity and things stretch, things sag, gravity works on the body and everything goes south, and we all want to look like children who have very plump features and very tight, taut skin. And therefore what we do is we often tighten the skin, and the way we tighten the skin is by removing skin and closing things tightly. And if you're going to remove skin, you're going to give a scar. That's the bottom line. There's a lot of ways that people say they can do things without doing surgery, and they can tighten skin and what have you, but really the best way to tighten the skin is to remove skin. If there was a way that we could somehow restore the elasticity of the skin, that would be great, but at the moment really the best way to tighten the skin is to remove skin. And if you're going to remove skin, you're going to cause scarring. So everybody wants less scarring, but less scarring means less skin removal, means less tightening, means less of a result. So if you haven't got much laxity, and that's the same whether it's in the breast or the tummy or wherever, then you can get away with less scarring. Now, specifically talking about breast reduction, there are different patterns of scarring that you can get with breast reduction. All types of breast reduction give you a scar around the nipple, and then you move on from that. The reason they all give you a scar around the nipple is because you have to move the nipple. The nipple's in a low place and you move it to a higher place. So they all give you a scar around the nipple, and then you can either have a scar going straight down from there, which is the lollipop, or you can have an anchor, which is a scar going down straight down there, and straight down from there, and then a horizontal extension. The technique that Deborah's talking about just gives a scar around the nipple and the horizontal, and it avoids the vertical scar between the two. And the problem that I can foresee with that one, Deborah, is that, as I said to you in the group, the problem I can foresee with that, if you don't have that vertical scar, then you're only taking skin out in an up and down direction from the breast. You're tightening the skin in an up and down direction. But one of the things about a breast reduction, one of the important things is to narrow the width of the breast. The breast is often quite wide. You have to look at before and after photos to see that. And you narrow the width of the breast. And that's what that vertical scar does, because if you look at the markings of a breast reduction, there's a sort of oblong shape for where the nipple is, and then there's two lines that go out, and they come together to form that vertical scar, and that narrows the breast, which is an important feature, an important part of breast reduction. So therefore I don't do that technique for breast reduction. I'm aware of that. I didn't know it was called the Hondesky procedure. I was aware of that type of skin reduction pattern, but that's something that you do in men with gynecomastia correction who've got a significant skin excess. I will use that, but a significant skin excess in a man is nowhere near as bad as a significant skin excess, is a sort of mild skin excess in a woman. So they never have as much skin laxity, even in a significant case of gynecomastia. So if I'm taking out less skin, I might give less scarring and use that technique, but not for breast reduction, less scarring. Same with tummy tucks. People want mini tummy tuck. Mini tummy tuck is great, but it does not get to remove as much skin. So you just have to be aware, less scarring means less skin reduction. So that's that type of breast reduction. There's also, we've got a question from someone who's asking if they can have surgery with, they've got hepatitis B. That's something which we have answered to that person, and it really depends on the surgeon, whether they would do a surgery on someone with hepatitis B. My personal view about that sort of thing is that with any sort of bloodborne transferable, transmittable disease, hepatitis B, and the other one obviously is HIV, my view is that we don't screen for this preoperatively. We don't screen everybody for these diseases preoperatively. So I think that we should treat everyone, as a surgeon, we should treat everyone as if they've got these diseases. And if you find someone who's got hepatitis B or HIV, you could argue, well, actually you're forewarned about that. And so you can put measures in place to minimise the risk. It depends on what the operation is. It depends on the surgeon, but it is not what we would call. It's not what I would call an absolute contraindication. I wouldn't just say no, I won't do surgery on you just because you've got hepatitis B, because the person after you might have hepatitis B, but we don't know that. So in a way, you could argue that because you know that you've got hepatitis B, you could put things in place. So my view is that I would still do surgery on someone with hepatitis B, but you have to talk to the surgeon. Anyway, you have to discuss what the operation is. I've got some questions here, but here's a question from Chris. Do you feel revision lipo had a very small spot area under the belly button and had zero blending in? Very small spot area. Revision liposuction, yeah. Yes is the answer. Two things about that. First thing, revision surgery, I would always say, Chris, that you probably best to go back to your original surgeon, because they would have a vested interest to try and get things right, and they would probably or possibly do something with regards to having to pay for it. Often you may not have to pay for it or pay some kind of reduced fee if things aren't quite right often things aren't quite right following surgery, particularly liposuction. Might do too much, too little, might have to have a revision. So I would say that you're usually better off going back to the original surgeon. But having said that, if you want to go somewhere else and come and see me, that's absolutely fine. You say a very small spot under the belly button. If there is just a small area in the abdomen, it might be amenable to revision liposuction. Might be an option. As a general rule, liposuction on the abdomen, I often feel it doesn't give great results because it doesn't cause skin retraction, like I was talking a minute ago about taking skin out. And often, if you leave a bit of skin behind, it doesn't give a great result. Best way to recontour an abdomen is with the tummy tuck, but by your question, you don't need a tummy tuck. It's just a small little bit, but under your belly button. Something you could consider, Chris, is something like VASER liposuction. VASER liposuction. There's assisted forms of liposuction. VASER, which uses ultrasound, and there's also laser-assisted liposuction, which is things like smart lipo. They're these machines that basically have a you're very welcome. But there's machines like VASER and smart lipo, and what they do is they produce some energy into the fat before you suck it out. There's two benefits in that. The first benefit is they use smaller cannula, smaller tubes, so they're less traumatic, so you can often be awake when you have those procedures. When I do liposuction, you're usually asleep, but with these types of liposuction, you're often awake. And the other thing about them, because they give some energy to the fat, that can sometimes cause some skin retraction. And that's often what you need in the tummy. You need skin retraction. So people who come to me for abdominal liposuction, I often recommend VASER or smart lipo, sort of laser type lipo. I don't do it though. So you have to find someone else who does do it. I just do a traditional power assisted or suction assisted liposuction. But often in the abdomen, then these other types might be something to look into. But if you want to come and see me, you'd be very welcome to come and see me. But I'll probably say this to you, that often VASER and other types are good for tummy. But I should do it really, shouldn't I? There you go. We've also had a patient who was having surgery this week and had a cold and was asking about whether she should come along, so we put that on the list. VASER, yeah. Recommendations. I'm pretty sure that CC Cat, I think, has got one. If you're in Birmingham, are you in Birmingham? If you're in Birmingham, CC Cat, I think, has got a VASER liposuction, or at least has access to it, or does it. I don't know anyone else who does it. I don't even know if I think she does it. But if you're in Birmingham, she's good. As ever, look for a plastic surgeon, fully trained. Look, you can get my book. I've got a copy here. Never accept a lift from strangers, but basically look for a fully London. Oh, there'll be people in London. You can welcome to travel to Birmingham, but there'll be people in London. Look for a fully trained plastic surgeon. FRCS Plast after their name. BARPS and BAPRAS have websites which have got lists of plastic surgeons, and I'm sure there'll be people in London who do VASER. I'm sorry, I don't know off the top who does VASER, but there's lots of good people in London. You're welcome. Marie has got a question here about the cold. Yes, the cold. So basically, the advice for someone, if you are having surgery and you've got a cold, my advice is always, if it as in this case, if it's sort of quite soon before the surgery, first of all, if you are feeling not very well, and you don't think you want to go into a surgical procedure, then you may want to postpone the procedure, which is perfectly reasonable. So postpone it, because I know you can feel pretty rough when you have a cold and you don't feel ill and you don't really want to be hit by a surgical procedure at the same time. But I understand sometimes people have worked out their work commitments and they want to have surgery anyway, and that's fine. So if you really want to have the surgery and you're just worried from a medical point of view if you're fit enough to have surgery, usually it's okay. But I would say to you, if it's quite close to the operation, which it usually is, because if it's far away before the operation, you're probably going to get over the cold. So it's usually the day before or a couple of days before the surgery. We're probably not going to be able to get anyone into that slot. So I would say to you, look, just come to the hospital, get seen by the anaesthetist, and he or she can make an assessment on the day. Or if you want, we can get the anaesthetist to give you a ring and talk to you over the phone to see how bad you are, to get an opinion on that. But it's usually okay if it's just a cold and you're not feeling too bad. It's usually okay to proceed with surgery, but it's usually elective operations, elective surgery, which means it doesn't have to be done, and so it's something that you have to be in tip-top condition. So if there is any concerns, any worries, then it's no problem at all to postpone it. But that's the advice if you do get a bit of a cold or a sniffle before your op. If you want to postpone, fine, but if not, come and talk to the surgeon. Can I, another one from the private group here asking if I can go to the water park after surgery. I think, this is Taryn, you're 2 weeks, are you 2 weeks post-op, I think, and you can go to the water park, you can, and you can get your scars wet, as long as you don't no longer needing any dressing. So what I think we've taken the dressings off and just given you some gauze to wear, and as long as that gauze is coming off dry and you haven't sort of got like an open wound, then you can go into the water. But what I would say to you is you've got to take it easy. I'd say take it easy for the first 3 or 4 weeks after surgery. You can do stuff, particularly lower body stuff. So walking is lower body stuff, I guess. So you can do walking, things like that. The exercise bike is good. Running and what have you is not quite so good, but because of the boom, boom, boom. So that's probably about a month or so for running. But certainly walking and things is good after 2 weeks. And getting wet, getting into the water is fine. But I won't go doing too much swimming, what have you. So messing about is fine, but just take it easy. It's a couple of weeks. Davina, we got some photos from you about your scar. Davina is, I think you're 2 months post-op, and you got a scar, and the scar was looking great initially, and then it's looking it's a bit red and a bit thickened now, isn't it? Don't worry, that's normal. Your scar is totally normal. I've posted this to you already, but that's the natural history of scars. Scars often look great when you first have it done, and then at 4, 6, 8 weeks they can look a bit thicker, they can go a bit redder, and that's just what happens to scars. As they start to knit together, it can get a bit. I hope you can't hear that in the background. I've got my microphone on, so I hope you're not picking up the noise. I don't know what's going on out there. They can get a bit knitted together, and it can get a bit redder, a little bit more firm. That's why after about 4 to 6 weeks I get you massaging it with cream, because it's often quite red and thick, and then it takes another couple of months for it to settle down. So it's totally normal. Your scarring is normal, and don't worry, that's absolutely fine. And just got an email from Ange. I don't know if you're out there. I don't know how I can tell who's out there. But you want a tummy tuck for an abdominoplasty for your 50th, and you're looking for the best surgeon. My book tells you how to choose a surgeon. Basically, as I said to Chris, look for someone who's fully qualified plastic surgeon. That might sound like a weird thing, because you might assume that everyone's a fully qualified plastic surgeon doing this stuff. They're not. There's not that many fully qualified plastic surgeons in the country, and there's a lot of people doing this who are not fully qualified plastic surgeons. Look for FRCS Plast after their name. You probably won't find anyone who specialises in tummy tuck, in just tummy tuck. There's a few specialties in plastic surgery: burns, hands, head and neck, breast, cleft. I think those are the main ones. Skin, those are the main ones. Skin being like skin cancers and things. Tummy tuck isn't one. Oh, awesome. Suzy, you come in with a question. Excellent. I'll sum that one up. Chris is going to feel bad now. I'm going to thumb Chris up. So, was I saying something about fully trained plastic surgeons? Not many in the country. Can't hear, but there's a loud buzzing. Oh, is it my new? Is it my new? Is my new? Is there a loud buzzing? Is it my new microphone? Oh no! Got a new microphone. I should have used the old one. Where's the other one? Oh god! Now you tell me. I've been waiting on for ages. Okay. Sorry. Is it bad? If it's bad, I'll take the microphone out. Okay. Oh, I was saying something about abdominoplasty. So yeah, fully trained plastic surgeons, not many in the country. Look for some. Oh yeah, no one specialises. No one specialises in tummy tucks. So yes, well, I don't know of anyone who specialises in tummy tucks. Okay, I'm going for it. Is that better? I've gone mic. The mic is out. I've got that other one, but I don't know where it is. The mic's out. We're freestyling it. Hope you can hear. Is that better with the buzzing? Anyway, I'm glad you could hear then. Better, okay. Oh well, that was money well spent. That lapel mic. I had it already. I had it for other stuff. So yes, look for a. Oh, this is big. Thank you. Right. Well, thanks for letting me know that it was buzzing. 20 minutes in. But anyway. Right. Okay. That's useful. So yes. So look for someone. So it's a plastic surgeon. No. Yeah. If you're looking for a tummy tuck, I guess people. For me, because of when I was in the NHS, most of my breast reconstruction I used was from the tummy. I did a lot of tram flap type things where you take the tummy tissue. So I did a lot of tummy work. So I mainly do breast and body, but most plastic surgeons will be doing tummy tucks. So yes, if you want to find the best, look for BARPs, BAPRAS websites. You can find someone, and that's how you find a good surgeon. And also meet them, meet a few. Don't worry about meeting a few. I think a lot of people get worried when they've seen other surgeons. I see people who feel a bit ashamed that they've seen other surgeons. We all know that you all see lots of other people. We know that, and that's fine. And I think any good surgeon will be happy that you're seeing other people. And if you get on better with the other person, then that's fine. No hard, that's okay. That's life. And so yes, see lots of people, or maybe not lots, but as many as you need to see. Look for before and after photos. Make sure it's there before and after photos. If you ask them about their qualifications and they get a bit funny about it, be worried about that. And that is the advice about choosing a surgeon. And recommendation. Look for someone's recommendation. Although it's not always easy to get recommendation. So Susie has saved you the question here, and we've got a question because I'm out on my list here. I'm going on the comments. Susie, after breast lift stroke reduction, do the sutures need to be removed? Are they dissolvable? I use dissolvable. I think most people use. I do a lot of these questions on Real Self. I don't know if you see Real Self. There's a Q&A thing, and a lot of times, I think it's always good to ask the surgeon that's doing it. I can talk in general terms, but really the surgeon that's doing it is the person who knows. So I use dissolvable sutures. I always use dissolvable sutures with breast reductions. I think most people do. But I don't know. Maybe some people don't use dissolvable, and they use. It's not perfectly reasonable to not use dissolvable sutures. And the difference between dissolvable and non-dissolvable is that non-dissolvable sutures you can predictably take them out at a certain time. And so if you're very worried about this getting the best quality scar and the skin's going to heal in a short time frame, you use non-dissolvable sutures. That's why we pretty much always use non-dissolvable sutures on the face, because the skin heals very quickly and you need a good quality scar. Somewhere like the breast, you want to have, it's more important that the sutures are in for longer, because you need to get the strength there, especially a breast reduction or a lift. You need the strength to be there for to get the wound to be healed, and so you want the sutures to be in there for longer. and the problem with dissolvable sutures is the scar does go a little bit red as it's dissolving, as Davina you have noticed, but the scar does go a little bit red while it's dissolving, and they can cause a bit of irritation. Sometimes they can spit out. So they can cause some problems, dissolvable sutures, but they stay there for longer, and that keeps the strength there and the wound healing and what have you. After about 6 months, a year, the result is the same, but dissolvable sutures, it's a little bit red in the first few months while the stitches are dissolving. But it's always a balance between the strength of the scar, the strength of the wound, how much tension it's been put under, and the part of the body that you're operating on. So, as I say, the face always heals well, so you pretty much always use non-dissolvable on the face. The trunk, the body, you often use, you often use, you usually use non-dissolvable sutures. There is one, if it's me, I always use my last suture is at a breast junction, at the T-junction. I always put on the outside, just because that's where the confluence of all the sutures are. It's the tightest point, and I always put the knot on the outside. So patients always think, hold on a minute, you've left the stitch there, because they can feel a knot at the outside of the skin, and they think, oh, he's left that stitch has to come out. It doesn't have to come out, it dissolves and just falls off, but I just deliberately, I try and tell people, I sometimes forget to tell people, and they think, oh God, he's left the stitch, but if they do say something, I'll say, oh, I haven't left the stitch, it's just the last one on the outside, because that's where all the stitches come together. So yeah, bottom line, I use dissolvable. Ask your surgeon what he or she is going to use, but I think a lot of people use dissolvable for those reasons, and we use several layers of dissolvable sutures. So excellent, thank you. I have sorry about the buzzing, first half of the thing, trying a new technique with a new mic. Back to the one in the white one in the ear, looks like, next week. And if you've got any more questions, go for it now, or email or post on Facebook or whatever, and we'll make a list and we'll go through them next week. So thank you all. I'm gonna sign off now. So thanks very much. Nice to see everybody here. Some old faces, but not, people I know. I mean, not old faces. And yeah, speak to you soon, and I'll do it again next week. I have above Susie. Yeah, I have above Susie. Yeah. Yeah. What's that mean, Mrs. Bick? Is that a question? Okay. I'm trying to think how that could have been a typo. Anyway, you have above Susie. Okay. So I'm going to sign off here, if that's okay. And yeah, awesome. Sorry, yeah. Can I sign off now, Mrs. Bick? Is that all right? Have I got any missed questions? I don't think I have. No. So I'm signing off, and I will see you soon, next week. Do it next week, Monday, or it's Tuesday today, isn't it? Maybe Tuesday. Bye. Thank you, Claire, and that's me. Good. All right then. Bye.